all others who are joining from the rest part of the world. Today, we have got two guest lectures at two different topics. Our first guest speaker is Dr. Astrid Pawlowski from Argentina, and our second guest speaker is Dr. Ryan D. Casade from Seattle, USA. Our first guest speaker, Dr. Astrid Pawlowski from Argentina, is going to lecture us on immunotherapy in Hodgkin's lymphoma. And following this, we have a question answer session, and then we have our second guest speaker joining us. That would be Dr. Ryan D. Casade from Fred Hutchinson Cancer Center, Seattle, USA, and who is going to lecture us on updates in the management of adults with Ph-positive ALL. This webinar is brought to you by Pfizer, Netco Oncology, Lucien Life Sciences, and Unipath Spatial Laboratory Limited. And this, as usual, is being brought to you by Mumbai Hematology Group and very well supported and managed by Perfect Square. I thank Dr. Prakash Singh Dio and Team Pfizer, Mr. Yash, Mr. Kalpesh, and the Team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speakers for the day, Dr. Astrid Pawlowski and Dr. Ryan Casade, all our discussants who are themselves very eminent hematologists as well as medical oncologists, and you participants for sparing the Saturday evening, morning, or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 17th of November 2024, from 11:30 a.m. Indian Standard Time and 7 a.m. French Time, we have Dr. Thierry Lamy from France speaking to us on LGL leukemia. Let me introduce our discussants for the day, and we have galaxy of them here displayed in alphabetical order. And in the event of time, I will just name them. To start with, we have Dr. Aditi Shah Kaskar from Borivali, Dr. Aditya Jandial from Homi Baba Cancer Center, Mulanpur, Punjab, Dr. Alim Jan from Srinagar, Dr. Amrit Kaur Keller from Mumbai, Dr. Amba Rasan Sekar from Tata Medical Hospital and Actrac, Mumbai, Dr. Ankur Ahuja from Pune, Surgeon Commander Dr. Arun V.A. from Mumbai, Dr. D.S.K. Sahitya from Vizag, Dr. Deep Gala from Lucknow, Dr. Dipjot Pusti from Cuttack, Dr. Dinesh Burani from New Delhi, Dr. Ganesh Jaishetwar from Hyderabad, Dr. Hamza Dalal from Mumbai, Dr. Hari Menon from Bengaluru, Dr. Hitha Diljit from Kerala, Dr. Jeevan Kumar Garg from Kolkata, Dr. Manoj Uni from Kochi, Dr. Mohammad Mir Hussain from Srinagar, Dr. Muhammad Rifai from Kerala, Dr. Nadeep Shoket from Jammu and Kashmir, Dr. Nakul Tikare from New Delhi, Dr. Narendra Agarwal from New Delhi, Dr. P.K. Sasidharan from Kozhikode, Colonel Dr. P. Suresh from Delhi, Dr. Pankaj Tatia from Bikaner, Dr. Pawan Kumar Singh from Gurugram, Dr. Pradeep K. Reddy from Chandigarh, Dr. R. Prasanna from Tamil Nadu, Dr. Rajesh Patil from Mumbai, Dr. Rajkumar Ramaswamy from Madurai, Dr. Ramesh Balasubramanian from Madurai, Dr. Rupam Deka from Guwahati, Dr. Sadashivudu Gundeti from Telangana, Dr. Satrupa Mahapatra from Bhubaneswar, Dr. Surprakash Sanyal from Mumbai, Dr. Thomas Kuncheria from Kochi, Dr. Vishnu Sharma from Jaipur. Now it's a time to introduce our first speaker for the day, our first guest speaker, Dr. Astrid Pawlowski from Argentina. Dr. Astrid Pawlowski is Medical Director at Pawlowski Center, Department of Hematology, Fundliu, Buenos Aires, Argentina. She's a specialist in internal medicine and hematology. She graduated from medical school with honors at the Universidad del Salvador, Argentina in 1997. She completed training in internal medicine at Hospital Italiano de Buenos Aires, Argentina for 5 years and continued her training in Fundliu as a fellow in hematology in Buenos Aires, Argentina. And today she is with us and she's going to lecture us on immunotherapy in Hodgkin's lymphoma. I stop over here. Over to you, ma'am.
Okay, thank you so much for this invitation. I'm very happy to be here and I congratulate you on all of this big academic activity that you're having. So This is, now you can see my screen.
Yes, ma'am. Perfect.
Yes.
Please go ahead.
Okay. So in Hodgkin lymphoma, we are witnessing very important changes with not only relapsed refractory Hodgkin lymphoma, but also now in first line. So the question is, where are we standing now? And are we ready to incorporate immunotherapy in first line Hodgkin lymphoma? So knowing that most of our patients will be cured, and today we have a very, very high overall survival for this group of young patients, what is the best first line treatment? And this has to include long-term outcomes with long overall survival. And this depends on two very interrelated factors. This is first to have a treatment with a high efficacy to eradicate lymphoma, but we're also facing and we're trying to have low acute and long-term toxicity, especially trying to avoid cardiovascular toxicity and second neoplasias, and a shorter overall survival due to toxicity from first-line treatment. So this is where most of cooperative groups are trying to get, how to eradicate lymphoma with a low toxicity. So for many times we have had two strategies, and this has been after the introduction of PET-CT adapted therapy. So these two different strategies or these two different philosophies depend on these two things, and strategy number one is to start with ABVD, and in this strategy we are trying to hit hard only on those patients who are interim PET positive, and we escalate intensity of chemotherapy. What is the thinking behind this? Is to avoid excess toxicity, to try to cure patients with less chemotherapy from the beginning, and to only intensify in a minority of patients. And then we have this other treatment strategy, which is to start hard first, to start with BCOP, to hit hard first, and then de-escalate in patients who are PET negative. And what is the main objective behind this strategy is to reduce early treatment failure. So this is where we have been up to now. And what are the different clinical trials that have these strategies and that we might be able to incorporate today? Well, we have this, first of all, the Rathers trial, and I'm sorry, but I want to specify that all of this is for advanced stage Hodgkin lymphoma. So we have the Rathers trial already presented years ago, in which they will start with 2 cycles of ABVD, and if PET was negative, trying to de-escalate and avoid excess toxicity, they randomized into 4 cycles of ABVD versus dropping bleomycin and going on with ABD. For those patients who are PET positive, which are usually around 30%, I would say, after ABVD, then only on this group of patients, they would escalate to escalated BCOP. And if PET was negative, they would go on, they would do 3 cycles, and if PET was negative, they would go on with BCOP. And they considered PET negative at the real score 1, 2, and 3. Then there's this other strategy, which is by the United States, which is by the LISA trial, where they start with 2 escalated BCOP. And if PET is negative, then they go on to ABVD. If PET is positive, then they go on to 4 escalated BCOP. So they de-escalate to ABVD. And then the standard arm is 6 cycles of BCOP for everyone. And then this last one, which is the HD18 trial from the German Hodgkin study group, where they were very fond of BCOP. So they started with BCOP. And if PET was negative, they de-escalated to complete only 2 more cycles of BCOP instead of the standard arm, where they went on to 4 more cycles of BCOP. And if PET was positive, then they would go on to more BCOP. So I'm sorry, let's see. So if we look at this, at the results of all of these 3 trials, we can say that in spite of de-escalating either the Rather trial, the AHL 2000, or the HD18 trial, we can see that all arms, when we de-escalate, the results are the same. So it's the same to go on in PET negative, to go on with, we can drop bleomycin. In PET negative after BCOP, we can go on to ABBD. And in PET negative after 2 cycles of BCOP, we can go on to complete only 4 more cycles of BCOP. So de-escalating is safe and its efficacy for this group of PET negative patients. Now, another question is, do we need radiotherapy in bulky disease? And this is one clinical trial which is especially designed to identify and to answer this question. So they included patients which were stage 2B to 4, and they gave 2 cycles of ABBD. If PET was negative, they completed 6 cycles of ABBD, and they randomized to see whether we needed, in PET negative patients, radiotherapy for those patients that had a bulky disease. So if we look at this, they randomized into radiotherapy versus no radiotherapy, and progression-free survival and overall survival was the same for all patients if they had achieved a negative PET-CT. So this is another clinical trial trying to answer this question, and this is all. They started with 2 cycles of ABBD, and then they performed a PET. If PET was negative, they went on to ABBD, and then they did end of treatment PET. And if PET was negative and patient had bulky disease at diagnosis, they randomized into consolidation radiotherapy versus observation. And once again, for patients who are interim PET negative and end of treatment PET negative, consolidation with radiotherapy didn't seem to be add any benefit. So we can say that patients with bulky disease and with interim and end of treatment negative PET may not need radiotherapy. Now, how are we today? Can we improve outcome in those patients who are interim PET positive? And this is one of the only randomized trial. No, this is the LISA trial where that PET positive went on to BCOP. And we can see these results. In the blue line, we can see patients who were interim PET negative and end of treatment negative, which is the blue line with excellent results. In the red line, we can see those who are interim PET positive, but then they went on to BCOP, which have a very good results, but not as good at interim PET negative. And in this last curve, we see those who are at end of treatment are also interim PET positive. Another way of intensification in interim PET positive, which is what is worrying us now, is this group from the this trial from the Italian group, where patients received 2 cycles of ABBD. If interim was positive, they went on to salvage therapy. If interim was negative, if PET after end of treatment was negative, they went on to autologous stem cell transplantation. If interim was positive, then they tried to have an allotransplant. So this is a very high intensification for PET positive patients. And what they saw is that in PET2 positive patients, if we go on to autologous stem cell transplantation, which was this treatment strategy for most patients, the overall PFS was 74%. So today we can say that intensification with salvage chemotherapy and autologous can be considered in a base-to-base patient, in patients who are interim PET positive, especially I would say that only for those who have a Deauville score after first cycles of chemotherapy. This is our experience from Argentina, where we did something different. We included all patients with all stages and treat them with ABBD, and if PET was negative, we stopped treatment. If PET was positive, we went on with ABBD plus involved field radiotherapy. And if it has a Deauville score 5, went on to salvage chemotherapy and autologous stem cell transplantation. And with more than 10 years follow-up, what we saw is that for all stages, if PET was negative, then progression-free survival at 5 years was 80% with only 3 cycles of ABBD, and for all PET positive being stages 1 through 4, PET positive patients had a PFS of about 65%. So this group with interim PET positive is what today is worrying us. So, but now we have something else. We have gone on to a different kind of therapy, which is the introduction of immunotherapy. The first drug that was introduced in first line was brentuximab vedotin, and this is the results of the Echelon-1 trial, where patients were randomized. More than 1,300 patients with advanced stage Hodgkin lymphoma were randomized in a one-to-one basis to receive either 6 cycles of brentuximab plus ABD versus 6 cycles of ABVD. And there was an interim PET, but no decision was made on interim PET. So we see that almost 650 patients were included in each arm. They were, most of them, the median age was 35, but they also included a percentage of patients that were older than 60 years. And this is the recent, very recent updated results presented in Cologne this year by Dr. Ansel, which show a PFS benefit in the arm that received brentuximab plus ABVD versus ABVD of 82 versus 74%. So this is more or less what we saw from the first publication, and this PFS benefit is seen even with longer follow-up. And what is surprising for me is that there was an overall survival benefit with 93.9 for the group with A plus ABVD versus 89 for the group of ABVD. So with a longer-term follow-up, we see this small but clinically or statistically relevant reduction in overall survival when using brentuximab in first line. So we recently, with a group of my colleagues, we published a study trying to see whether we could identify from this data from the Echelon-1 trial, patients who can benefit most from this treatment strategy, and patients with higher risk have the strongest benefit of including brentuximab in first line. Who are these patients? Patients with stage 4, patients with high IPS, patients with more than one extranodal site, and patients who are younger than 60 years, because in older patients, toxicity was also an issue. In the pediatric setting, there was also a randomized trial with very much the same idea, changing including brentuximab and in their usual standard of care, which was ABVE plus PC, and they had 2 cycles interim PET, and then they went on to receive 3 more cycles, and they irradiated only patients who were interim PET positive. This was this experimental arm, and the standard arm was with chemotherapy and the same strategy. They included patients which were from age 2 to 21 and only advanced stage PET positive patients. And also what they saw is a benefit, and let's look at this young group of patients where the benefit of including brentuximab was even higher, 92 versus 82%. And this benefit was seen in all subgroups. So brentuximab vedotin in combination with chemotherapy was associated with superior progression-free survival among children and adolescents with high-risk Hodgkin lymphoma. What about the German study group, which they were stuck to BCOP and they did not want to include a PET-adaptive therapy? Well, we saw from the previous results that they finally did include a PET-adaptive therapy, showing that in PET-negative patients, we could give only 4 cycles of BCOP instead of their usual 6 cycles. But then the German study group also decided to incorporate brentuximab in their first-line treatment, so they remodeled BCOP. What they did, and here in gray we can see BCOP, and they said, we have to retain this high intensity in first-line treatment, so they retained doxorubicin, cyclophosphamide, and etoposide, but then they introduced brentuximab in the new regimen, and they omitted bleomycin and vincristine due to pulmonary and neuropathy toxicity. They also replaced procarbazine for dacarbazine to try to have less genotoxic toxicity, and they replaced prednisone with dexamethasone also to avoid toxicity. So there was this new regimen called BRICAT, designed also by the German group, and they did 2 cycles of either BRICAT or their standard 2 cycles of BCOP. And if interim PET was negative, they went on with 2 more cycles of BRICAT or 2 more cycles of BCOP on the standard arm. And if interim PET was positive, they did 4 cycles. So it's the introduction of a new regimen and a PET-adapted strategy. And they wanted to demonstrate superior tolerability defined by a reduction in treatment-related morbidity and demonstrate non-inferior efficacy. And actually, this was a positive trial. They showed that BRICAT had a higher progression-free survival of 95 versus 92%, which they for the first time, they show a treatment strategy which is even more efficacy than BCAT, and with the same overall survival, with an overall survival of 98% in both arms. The improvement in PFS with BRICAT was seen across all age groups, except maybe for patients who are older than 50 years old, because although this is less toxic, it's still a toxic regimen. What about reduction of toxicity? We all know that BCOP is very effective, but many of us don't use it due to toxicity. And they showed a reduction in treatment-related morbidity, a reduction in transfusions, but still there are transfusions in this treatment strategy. Polyneuropathy was reduced, but still we see some neuropathy, and treatment-related mortality was 0%. So they concluded that BRICAT is significantly better tolerated than BCOP, and that the superior of this new regimen is superior to escalated BCOP. So now the German study group is recommending individualized PET2-guided BRICAT as a preferred regimen for advanced stage classical Hodgkin lymphoma. And what about the introduction of this other group of drugs, the checkpoint inhibitors? And this is a very important trial, which is the SWOG S1826 trial, where they also included patients with advanced stage Hodgkin lymphoma. They included patients who were 12 years old or older, this is something new, to include young patients in the adults trial. And they randomized patients to nivo-AVD versus VV-AVD, with primary endpoint being progression-free survival. They included almost 500 patients in both arms. As said, 25% of the patients were younger than 17, and 10% were older than 60. And most of them were stage 3 or 4. Only 1 patient was not reported. And these are very newly presented results. These were presented just 2 weeks ago in the German Hodgkin Study Group meeting, with VV-AVD showing a 1-year PFS of 86% versus nivo-AVD of 94%. So this is almost a 10% or 8% advances in between these 2 new regimens. If we look at the subgroups, all subgroups were benefited regarding in favor of nivo-AVD, and the overall survival was 99% and 98% for all of these patients. If we look at the pediatric cohort, which is new for us who see adults to look at this group of patients, the difference of PFS was even greater with the use of nivo-AVD, with a PFS of 95 versus 83%. So here we are with new options in first-line treatment for Hodgkin lymphoma. So what can we say about incorporating immunotherapy in first line? Well, definitely we think it's safe. We can omit bleomycin, especially for some group of patients where we're worried about this drug. And we have seen and also with a longer follow-up, an improvement in progression-free survival and overall survival with VV-ABVD. Now, the question is, when we look at the Echelon-1 trial, is should we select a high-risk group of patients? As said before, maybe there's a proportion of patients that can have even a greater benefit from this treatment strategy, which are stage 4 IPS, high IPS, extranodal disease. And then another question is this suitable for all ages, or should we select younger than 60 years old due to toxicity? And when we look at the SWOG study, we can say that there's a security and higher progression-free survival with nivo-ABVD versus VV-ABVD. There's this big important thing that patients who were older than 12 years were included, that there was a very big reduction in radiotherapy. For younger patients, only 1% of the patients received radiotherapy, and for the pediatric group, in previous clinical trials, about 50% of the patients received radiotherapy, so this is something to keep in mind. And the future, this group of patients will share with us an analysis on ctDNA and a total metabolic tumor volume that is now ongoing. So there's still some open questions. They presented the 2-year progression-free survival. So do we need longer-term follow-up? What about long-term toxicity, especially in young group of patients? Can this worry us, or are we ready to go on to incorporate nivo-ABVD as one of the options for first-line treatment? So these are very good new options. This treatment combination has not yet been approved, I think, in no country. Nivolumab is not approved in first-line therapy for any country yet, but probably these results will change. And there's still some open questions in 2024. One of the questions is ABVD dead? So we can look at these questions and then we can discuss them. Is this the end of BCOP? And another question is, these 2 clinical trials that I just showed you, the Echelon-1 trial and the SWOG trial, do not use PET-adapted therapy. So are we done with PET-adapted therapy after all of these decades where we have learned a lot? Well, my question is ABVD dead? Well, I don't think so. I think still many patients are cured with ABVD. And for people who use ABVD as first-line therapy, this might still be a treatment strategy, especially if we're not incorporating brentuximab vedotin, maybe due to economical reasons, or maybe because we think that only a small proportion of patients actually benefit from incorporating brentuximab vedotin. Now, is it the end of BCOP? I think probably yes, because for those patients who use BCOP as first-line treatment, well, now we have a more effective strategy and a less toxic strategy. Now, although it is less toxic, it is not as easygoing as ABVD. That's why I think maybe ABVD still has a role for some hematologists that are not using such toxic regimens. And another good thing about using BRICAD or PET-adapted BCOP, this is a very short regimen. In 3 months, patients will finish strategy, but still many people using BV or BRICAD need to be admitted to their hospitals, need to live near a health facility, and maybe there's a proportion of patients who still need transfusions. So I think BRICAD will eventually replace BCOP for those areas where BCOP was used. The other question is, are we done with PET-adapted therapy? Well, hopefully not. These strategies that have been approved or that have been presented do not use a PET-adapted strategy, so we are not ready. We don't have enough data to use VV-ABVD or nivo-ABVD with a PET-adapted strategy. But hopefully in the future, we will see how some of these new treatment strategies can be adapted to PET. I think there are some future studies that will incorporate PET, and also that they will combine more sensitive strategies for responsive evaluation as it is ctDNA. There's a lot of research going on ctDNA trying to classify as better risk groups both PET negative and PET positive. For example, PET negative patients that have a positive ctDNA are the proportion of PET negative patients that will probably relapse. So maybe in the future we could incorporate also ctDNA as a response assessment strategy. And also there's ongoing research to determine baseline parameters to establish treatment intensity in first-line treatment. For example, metabolic tumor volume, also ctDNA, and we see that patients with baseline high tumor metabolic volume have a worse prognosis than those with low, and also patients with high ctDNA at diagnosis might also be a high-risk group, or even patients that have a very low percentage of lowering of ctDNA after just small courses of chemotherapy. So I think we're all going through a very interesting area. For many, many years, the only discussion was ABVD versus BCOP. Then the discussion became to be whether we should or not incorporate PET-CT adapted therapy. And now the big discussion is whether we are ready to incorporate immunotherapy in first-line treatment. And now there's even a further discussion is whether VV-ABVD should be incorporated, or can we all switch to Nivo-ABVD for patients older than 12 years old with advanced stage Hodgkin lymphoma. So I think we're very lucky. We are witnessing a great progress in first-line treatment of Hodgkin lymphoma, and this has a true impact on progression-free survival and overall survival for our group of patients. So thank you very much. Now I think we have time to discuss, and I will stop sharing and share with you your thoughts and opinions.
Thank you, ma'am, for a wonderful lecture, as always. It's always worth listening to you. Last time also you were superb, and this time you're fantastic.
Okay, thank you.
I request our Indian colleagues and discussants to please put their hand inside so that we can start our question answer session with Dr. Astrid Pawlowski, ma'am. So there is one question from the audience. What is the role of radiotherapy when using upfront immunotherapy? This is from Dr. Satrupa.
Okay, thank you very much for your question and for listening. This is a very important thing. The point is that we are reserving, in these different trials, they reserved radiotherapy only for patients who were PET positive at end of treatment. And even in patients in the SWOG trial, even patients who were PET positive, Deauville score 4, some of the patients were not irradiated, and they did a watch and wait policy, because we know that some of the patients who are PET positive are actually a false PET positive after using checkpoint inhibitors. So this was only a very, very small proportion of patients who were radiated. For younger patients, only 1% of the patients were radiated. I think this is a very big step forward in the treatment of advanced stage Hodgkin lymphoma. So with Nivo-ABVD, most of our patients will not need radiotherapy. But in case that they do have a PET positive, and in case that we have a clinical thought that patients need to receive radiotherapy, this is not contraindicated. We can do radiotherapy in patients with which we believe that they can have benefit after Nivo-ABVD.
Thank you, ma'am. any discussions? Want to ask any other question? Yes, one more question has come from Dr. Nakul Tikare. In a case of bulky disease with interim or end of treatment PET CT scan showing a dual score of 3, is there any specific approach with respect to radiotherapy?
Okay, this is a very good question, and I don't have the exact answer because I think that we might be able to consider differently interim PET than end of treatment PET. For interim PET, Deauville score 3, it depends on the clinical trial that was published. Some people consider Deauville score 3 positive, and some people consider Deauville score 3 negative. So I think we have to follow the different clinical protocol. For end of treatment PET, Deauville score 3 is considered a PET negative. So the big question is whether patients with bulky disease and a PET negative at end of treatment need radiotherapy. This is a big discussion, as shown in the lecture. There are 2 clinical trials addressing specifically this question, and it seems that patients with an end of treatment of PET negative do not benefit from radiotherapy. In our experience, we also have patients with bulky disease that have interim PET negative and end of treatment PET negative, and we did not give radiotherapy to this group of patients. I think this is something very much in discussion. I think every patient has to be treated in a personalized ways, trying to identify risks and benefits of radiotherapy. But I think there's enough evidence not to give radiotherapy for patients who are PET negative, including Deauville score 3. But this has to be taken in a very personalized way.
Thank you, ma'am. Another question from Dr. Anuj. What are the options for patients who are ineligible for bleomycin and cannot afford Nivo or Pentuximab?
Okay, this is a very good question also. I think this depends a lot on the age of the patient. First of all, we have to define who are patients who are ineligible for bleomycin, because there's also some confusion regarding this. If patients, for example, is a strong smoker, a heavy smoker, or patient has other risk factors for pulmonary disease, this doesn't always mean that patients will have toxicity, okay? Being a heavy smoker or having other diseases doesn't predict necessarily that the patient will have toxicity. So that is one question. Another question is, can we drop bleomycin? We might be able to drop bleomycin, but we are losing efficacy. If we give ABD, and this was shown by the German Hodgkin study group, we still have good results, but we lose efficacy. So in some patients, maybe older patients, we can have a balance and we can maybe drop bleomycin, right? Another thing is that we can do a very early PET adapted strategy. Maybe we can have 1 cycle of ABBD and then have a PET CT, and if many patients have PET CT negative after only 1 cycle, and then I would think it's safe to drop bleomycin. So I think there isn't another drug that has been evaluated to replace bleomycin, but I think we do have different strategies to try to avoid many cycles of bleomycin.
Thank you, ma'am. Dr. Ramesh, your question, please.
Good evening, ma'am. That was a wonderful presentation. So I have a question. In the era of immunotherapy, where do you place the role of allogeneic transplant in a relapsed Hodgkin lymphoma in a resource-constrained setting like us?
Okay, that is an excellent question also. That is on the relapse setting. Who are the patients that we think need to receive allotransplant? So this is also a big discussion because not everyone has the same opinion. I think that patients who relapse maybe after autologous, one thing, I think that if patients relapse after first-line chemotherapy and then go on to salvage chemotherapy, including either brentuximab, pembrolizumab, or nivolumab, and achieve a CR, I think these patients have to give the opportunity of consolidating with autologous stem cell transplantation. Okay, so I don't think that patients should skip autologous stem cell transplantation to go on to allogenic transplantation. But for patients who relapse after autologous stem cell transplantation and they received immunotherapy, the question is, if they are in CR, should they go on to consolidate for allotransplant? And I think that the answer is not always, okay? I think that for patients who, for example, have a negative PET-CT after pembrolizumab and chemotherapy, they have a fair good probability of maintaining CR for a long-term outcome. And what is the role maybe of patients of allogeneic transplantation is for patients who do not have a CR after immunotherapy. For example, if I treat patients with immunotherapy after a relapse for autologous stem cell transplantation and they do not achieve a CR, but they have a very good PR or a very good control of their disease, these are patients that will most probably relapse after time because it is necessary to have a CR to have the probability of continuing or being cured. So patients who have a PR or who do not respond with a CR, those are the patients that I would consider for allotransplant. Also, the patients in which I gave the opportunity because they had a CR after immunotherapy and then relapse, then these patients might also have be an option for allotransplant. So to answer your questions, I don't think all patients need to go to allotransplant. I think there's a probability to avoid allotransplant in a big percentage of patients. And I think some patients have long-term remissions after achieving a CR to immunotherapy.
Thank you, ma'am.
Was that clear or not?
Yes, ma'am. It was clear.
Absolutely clear. That was fantastic. So, in a nutshell, if a patient achieves PR after autologous stem cell transplant and remains on PR even after immunotherapy, then these are the candidates to go for allogenic stem cell transplant. And the second,
absolutely,
but if the patient was on CR after immunotherapy and relapses after the CR on immunotherapy, then the best would be to go for allo stem cell transplant.
Thank you. Excellent summary.
Thank you, ma'am. Thanks a lot. Another question has come from Dr. Mir Mohammad Hussain from Srinagar. Do you feel that there is some limitations with both Echelon-1 and SWOG trials, that is treatment de-escalation as well as omitting of interim PET? Because we do have very good results from Rathel and LISA trials in both ABVD and BIACOP respectively on treatment de-escalations.
Absolutely. Absolutely. I think there's one step forward to go with these trials is to try to de-escalate for a group of patients. So I absolutely agree. That's why I think there's probably ABVD is not dead. I think the results are excellent with all of these PET-adapted strategies, especially if we compare them to VV, to the Echelon-1 trial, where I think many of these patients might be overtreated because to give 6 cycles of VV-AVD without interpreting interim PET results, it's like maybe many patients will be overtreated. The problem is that we don't have enough data to adapt therapy or to de-escalate in this group of patients. But I agree with you that we have very good results with the Rathel trial. I don't use BIACOP in first line because we use ABVD, so I don't have so much experience in using, the German Hodgkin study group. But the question is about Nivo AVD, which obviously I also don't have experience because this hasn't been approved, but I think this is a very good step forward because we have less toxicity and even better results than BB-AVD. And the next step, as you mentioned, is whether we could do a PET-adapted strategy in this group of patients. Hopefully, we will have a new publications trying to see if we can reduce treatment even in this group of patients.
Thank you, ma'am. Ma'am, from the same note, if we start with ABVD, and if the patient has interim PET2 positive, normal funda what we have is to escalate to escalated BIACOP. So in place of escalated BIACOP, can we switch over to Brecard?
Obviously this is not published, but I absolutely think this would be a great idea if we could do it to introduce brentuximab, a less toxic regimen and a more efficacy regimen. I think this would be a great clinical trial we could do. Excellent. Yes.
Thank you, ma'am. Another question has come from Dr. Shailesh. What is the long-term outcome, that is 15 years or more, of patients who relapses after of relapsed Hodgkin's lymphoma following autologous stem cell transplant? And do all these patients relapse eventually?
No, absolutely not. After autologous stem cell transplantation, and this has been seen in historic data, there's approximately a 50% cure rate, yes? And we see from the ATHERA trial that if we do consolidation, there's a higher progression-free survival, but no changes in overall survival. So when we do consolidation, we are omitting some of the relapses, but still, but for those who relapse, we can rescue them. So many patients are cured with autologous stem cell transplantation. Autologous stem cell transplantation is not over yet. There are some trials that we're trying to identify whether we could do only immunochemotherapy after progression and avoid transplant, but this has not yet been shown. And I think for the time being, it's safe to still do auto transplant in patients. And about 50% of the patients can be, or maybe more today with a PET-adapted strategy, can be cured with autologous stem cell transplantation, even with a long-term follow-up.
Thank you, ma'am. Another question Dr. Shailesh has is, in case of relapsed Hodgkin's lymphoma after brentuximab, how do you choose between nivolumab and pembrolizumab?
They're the same. They're absolutely the same. What I do is I follow the publications. For example, Pembro GVD. I use Pembro GVD a lot. I have been using that as my first choice. Or Nivo ICE is another published strategy. But Nivo and pembrolizumab have the same efficacy and the same safety. So there's no difference between choosing one or the other. And there's no point in changing from one to the other if the patient has not achieved a good response. So whatever is available or whatever you choose, or I just stick to what has been published, whether, the combination that has been published.
Thank you, ma'am. Another question has come from Dr. Kunal Chetani. He has a case. He is a patient of stage 4 classical Hodgkin's lymphoma, received 6 cycles of ABVD. Bleomycin was withheld in the 6th cycle due to pulmonary infiltrates. Interim as well as end of treatment PET was negative. Now the patient relapses after 8 months of stopping the therapy. So can we go for brentuximab vedotin now in this setting, followed by autologous stem cell transplant?
Okay, so this is very good. This is an early relapse. Most patients that relapse will do it during the first year, so this is a typical case. I think, yes, you need to go on to salvage chemotherapy plus autologous stem cell transplantation. I would rather choose pembrolizumab plus GVD other than brentuximab plus chemotherapy, because this is an early relapse and this is a high-risk disease. And if I would use brentuximab, I would not tend to use it as monotherapy. I'll say brentuximab as monotherapy gives around 35% CR rates. If you want to do, there are two strategies if we're using brentuximab. The first one is to combine brentuximab with chemotherapy, either brentuximab plus bendamustine or brentuximab plus DAP or brentuximab plus ESHAP, giving almost a 75% CR rate. So we're going from 35 to monotherapy to 75 with combined therapy. One strategy that can be used is not to use combined, but to use a sequential. So you can do brentuximab monotherapy for 3 cycles. And if PET is negative, then you can go on to autologous stem cell transplantation. If PET is positive, then you can add chemotherapy and then go to autologous stem cell transplantation. So the questions are, we need a salvage regimen. We need to try to get a negative PET CT. I think you can use brentuximab, but if used as monotherapy, you have to evaluate very early and add chemotherapy afterwards if PET is positive. And also, and you can use it even if the patient had to drop bleomycin, but I would try to consider also pembrolizumab or nivolumab, being that this patient is a primary or an early relapse, not a primary refractory, but an early relapse, and these are high-risk patients.
Thank you, ma'am. So there are no more questions from the audience. Any discussion want to ask any other question? I think with that, ma'am, thank you so much. There are no more raising signs. And I think we have finished the questions from the chat box. And thank you, ma'am, for joining us today again as our guest speaker. You're super, fabulous, fantastic. Orange, big ocean.
Thank you. Thank you all very much. It's really very exciting for me to reach out to such a faraway country from Argentina to India. So thank you very much for your interest and for inviting me, and congratulations on doing so much academic work even on weekends. So congratulations. Thank you very much.
Thank you, ma'am. Thanks a lot. Thank you so much.
Bye-bye.
Thank you. So with this, we move to the second lecture for the day. Nikhil, has the second speaker joined?
Sir, not yet. I guess he will join by 7 o'clock.
We have still time.
Yes.
I will just finish the introduction then. Or should we wait for 5 minutes?
Yeah, we can wait for 5 minutes and then we start.
Okay. We'll take a break for 5 minutes.
Sorry, my computer was muted there.
Yeah, how are you, sir?
Good. How are you?
Absolutely fine. We were waiting for you. We just finished our first lecture.
Okay,
So if you're comfortable, should we start? I should introduce you.
go ahead. Yeah.
Right.
So we can start.
Yeah.
Sounds good.
Well, so our second guest speaker for the day is Dr. Ryan D. Casade from Fred Hutchinson Cancer Center, Seattle, USA. Dr. Ryan D. Casade is Associate Professor at Division of Hematology and Oncology, University of Washington School of Medicine, Associate Professor, Clinical Research Division, Fred Hutchinson Cancer Center, Seattle, USA. He completed his undergraduate and medical training at the University of Wisconsin in medicine. In 2010, he started Hematology Oncology Fellowship at the University of Washington and Fred Hutchinson Cancer Research Center. He then joined the faculty at these institutions in 2014 with a focus on acute lymphoblastic leukemia in adults. Since then, he has led several investigator-initiated and industry-sponsored clinical trials of various strategies for this disease, including novel agents and cellular therapies. He has a particular interest in developing novel chemotherapy strategies for high-risk populations, including older adults and those with relapsed refractory disease. He has served on the NCCN Guidelines Panel for Acute Lymphoblastic Leukemia and the Leukemia Working Group of the Southwest Oncology Group. And today is with us and is going to lecture us on updates in the management of adults with Philadelphia positive ALL. Well, thank you so much. Over to you, sir.
Thank you very much for having me. It's a pleasure to speak to you all. Let me just get my slides set up. See, screen one. I'll get this into a better looking. All right, does this look okay, Dr.
Absolutely.
Khurana? Great. Okay. So again, I will be talking about updates in the management of adults with Philadelphia chromosome positive ALL, a topic that has gotten increasingly complicated over the last several years. I'll begin by covering some of the chemotherapy-based strategies for this disease, then touch on some of the newer immunotherapy-based strategies for Ph-positive ALL. I'm also going to talk a little bit about Philadelphia chromosome-like ALL, Ph-like ALL, a disease that many think we might end up treating similarly to Ph-positive ALL someday, but and I'll talk about why we may or may not be at that point today. And then I'll also talk about some technical and practical issues regarding measurable residual disease, or MRD, testing and how it has become particularly important in managing ALL. So for chemotherapy in the frontline management of Ph-positive ALL, for many years, those of us in this field often cited this study as perhaps the most important trial to help decide between treatment approaches. So this was the SWOG 0805 trial that studied the intense chemotherapy regimen hyper-CVAD in combination with dasatinib. Importantly, patients on this study that had a matched donor were encouraged to undergo allogeneic transplantation in first remission, and then this would be followed by dasatinib maintenance. So that's a rather intense course of treatment that would span many years. And those who were able to successfully complete that approach are shown on the blue dashed line on these curves. You can see the relapse-free and overall survival were approximately 80% long-term. So these were very encouraging data, but obviously a very challenging course of treatment. For those that couldn't undergo transplant for whatever reason, and of course there are many patients who can't, those are largely depicted on the red curve, but still showing relatively good outcomes, even for those that didn't get a transplant. So for a long time, this was viewed as the standard, or certainly a good standard. But of course, these intense chemotherapy regimens can be very hard to give, particularly to older adults. So there have been strategies that have looked at less intense chemotherapy. One shown on the left is a study done in Europe using a regimen called the EWAL regimen. This included dasatinib and a low-intensity chemotherapy regimen. Survival curves not looking quite as good there. And then we studied an approach, the dose-adjusted EPOCH regimen, historically used for aggressive lymphomas. We use this for adults with ALL, including for Ph-positive ALL, where it was combined with either imatinib or dasatinib. And you can see the survival curve showed there. Not quite as good as the hyper-CVAD and transplant approach, but maybe a little less of a sacrifice in terms of complexity. And we actually took this a step further and tried to understand how does this regimen compare with hyper-CVAD. So, this was a single center retrospective comparison. This was not a randomized comparison. So we were able to find 69 patients in our historical experience who had gotten hyper-CVAD with or without a TKI, but would have met eligibility for that dose-adjusted EPOCH clinical trial. We then compared them to the 53 patients who were actually treated on that clinical trial. For the Ph-negative disease, the outcomes seemed to favor hyper-CVAD. The response rates were pretty similar, but survival looked better for those that got hyper-CVAD. But for the Ph-positive cohort, the outcomes were actually very similar, both in terms of response rates and survival. And interestingly, there was significantly more febrile neutropenia and significantly higher rates of life-threatening or fatal complications with hyper-CVAD than compared to dose-adjusted EPOCH. And furthermore, there was also a much higher reliance on transfusions for patients that got hyper-CVAD, both for packed red blood cells and for platelets. So what we concluded from this comparison is that generally, hyper-CVAD is probably still the preferable regimen, but dose-adjusted EPOCH could be considered as an alternative in certain situations, like resource-limited settings for patients that had a lot of comorbidities, for whom you're nervous about experiencing those life-threatening side effects. But it also could be a useful backbone for testing novel agents as opposed to hyper-CVAD, again, because of its toxicity profile. Now, if we stick with chemotherapy for Ph-positive ALL, and we're including TKIs, of course, transplantation has historically been an important part of this approach. And with that, as was done in the SWOG 0805 trial, maintenance tyrosine kinase inhibitors are also fairly commonly employed. However, when you actually look at the evidence available to support that, it's fairly modest. So expert opinion suggests that it is a, quote, valuable option, which I guess is worth something. But there's really no consensus on the preferred agent, how long, how to monitor folks on it, and so forth. To my knowledge, there has been one attempt to do a randomized controlled trial trying to address this question. It was a small study using imatinib, where patients were compared either with a prophylactic approach where everybody got it, or in a so-called MRD triggered approach, where basically if patients had evidence of detectable MRD after transplant, they were then started on imatinib at that time. And you can see from the survival curves, really the outcomes in these two groups of patients were very similar. So what do I do in my practice? I generally recommend patients get maintenance TKI for 1 to 2 years after transplantation. I generally don't continue it longer than that. If they had a good response to their upfront therapy that included a TKI, like they achieved an MRD negative remission, I will generally continue that same TKI post-transplant. But for those that didn't have such a good response upfront and then get a transplant, I'll often look to switch their TKI to something else, with the idea being, whatever agent they got up front wasn't very effective then, it's not likely going to be better after transplant. And speaking of TKIs, this then brings us to ponatinib, which has now increasingly become a part of frontline combinations. So there have been several different studies that have looked at this. There was a study done in Italy on the left where they combined ponatinib and prednisone alone for older adults with Ph-positive ALL. And while this was a very effective strategy initially, a lot of patients responded. Unfortunately, most patients would ultimately relapse. The group at MD Anderson has since studied the combination of ponatinib and hyper-CVAD, and that's shown on the right. There was a recent 80-month follow-up report that this group published showing that the 6-year overall survival was 75%. So very, very good long-term outcomes with this approach. And when we try to understand how this might compare to other strategies, there have been a few attempts to do that in a retrospective fashion. So again, the group at MD Anderson did a propensity score analysis from patients who were treated with hyper-CVAD and TKI at their center. So not a randomized comparison, but sort of a matched cohort comparison of sorts, and you can see the red curve on the left showing the patients who got ponatinib seemingly doing quite a bit better than those who got dasatinib. The curve on the right, just a single arm experience, but from an institution in California, just to show what another center was able to demonstrate very good outcomes with hyper-CVAD and ponatinib here. It looks like only one early event and everybody else was still alive. And this really leads us to this large prospective randomized controlled trial that was just published earlier this year, the Falcon trial. So this was a study of reduced intensity chemotherapy that was modeled after that EWAL regimen that I cited before, that randomized patients between ponatinib and imatinib. So they were randomized 2-to-1 so that more patients got ponatinib. The primary endpoint they called MRD negative CR after induction. So this was a composite of two things. One, they had to have a very low level of detectable BCR-ABL transcript or no detectable transcript, and they had to achieve the thresholds for morphologic remission, so less than 5% blast, recovery of blood counts, at least at 4 weeks. They used a response-adapted dosing strategy with ponatinib. So what that means is they started everybody at 30 milligrams daily, but then once those deep remissions were achieved, patients could drop down to 15 milligrams daily, hoping that that might mitigate some of the toxicity of ponatinib. And importantly, ponatinib led to much higher rates of these deep remissions. So you can see about twice as many patients were able to achieve MRD negative CR, including MRD negativity after remission induction. And while the survival analyses are still limited because the follow-up on this trial is still relatively short, it's less than 2 years, you can see the progression-free survival, which is depicted on the top, looks quite a bit better for ponatinib. Still no clear benefit in terms of overall survival with ponatinib, but again, this could just be a matter of not enough follow-up. And then lastly, the AE rates between these two arms were comparable, including for vascular events. So seemingly this approach, particularly the response-adapted dosing strategy, does appear to be safe and no more toxic than what we would expect with imatinib. But the question really that many will ask about this trial is why was imatinib used as the control? Wouldn't dasatinib have been a better control? SWOG 0805, lots of other trials have used dasatinib. It was really a practical decision since dasatinib was not available as a frontline TKI in many of the countries where this study was performed. They had to go with imatinib. So unfortunately, that's just the way that it worked out. But suffice it to say, ponatinib does look to be superior in this setting. Now, switching gears a little bit, we'll turn to immunotherapy in the frontline management of Ph-positive ALL. And really, blinatumomab is the agent that has set a foothold here, in part because of a couple trials that I'll mention. So the first is the DALBA study, so a study that was done in Italy that looked at a combination of blinatumomab and dasatinib in the frontline setting. So these patients were largely older, median age was 54, and their treatment is depicted here. So everyone received a course of steroids and high-dose dasatinib as their initial therapy. The steroids were stopped after about a month, and then the dasatinib continued as a single agent for another 2 months. So 3 months total of dasatinib. Thereafter, blinatumomab was added to the dasatinib for anywhere between 2 to 4 cycles, and then they received IT chemotherapy along the way. This approach did not yield particularly high CMR rates. You can see even after blinatumomab was started, only about a third of patients had achieved complete molecular response, meaning no detectable BCR-ABL transcript. And there are subgroups that seemingly don't fare as well with this approach, including the so-called IKZF1 plus signature. These are patients that have focal deletions of the IKZF1 gene plus other genetic abnormalities that require special testing to identify these. But if you identify them, unfortunately, they don't do very well with this. But you can see on the right here, these survival curves, particularly those that achieved a deep remission. Those are the blue lines. No events have observed yet in those patients, so very good results. And now the median follow-up from this trial is over 4 years. So we're now getting into a range where, if patients were going to be relapsing on this strategy, we likely will be, capturing them with this follow-up. The other approach that's important to appreciate is the combination of blinatumomab and ponatinib. So this was done at MD Anderson. This included, again, a similar cohort of patients, median age of 55. Importantly, about a third of these patients were actually already in remission when they enrolled on the trial, including a handful that were in a very deep remission. So for these patients, this was really more of a consolidation strategy, not really an upfront approach. The treatment was very simple. It was just blinatumomab and ponatinib, just those two drugs. The ponatinib, again, was used at sort of that similar response-adapted dosing where 30 milligrams was used up front and then dropped to 15 once CMR was achieved. The rates of CMR with this approach were quite high. You can see, 83% were able to achieve that depth of response at some point during the treatment. Only 2 patients on this trial underwent transplant up front. While the relapses have been infrequent, a relatively high proportion of them have been isolated to the CNS, which is a bit concerning and might identify a bit of a weakness with this approach that these investigators are still trying to figure out how to overcome. And the other thing is the follow-up on this is relatively short still. There's only about 2 years of follow-up. But you can see the survival curve shown here on a recent update of this trial showing very good very good event-free survival, is the red curve. Overall survival shown below. So fortunately, these responses are frequent and appear to be durable for some of these patients. But again, more time will tell if these responses hold up. So when you take all these different approaches and consider what are the optimal approaches to frontline treatment, chemotherapy, immunotherapy, just as a brief aside, I'm not typically using rituximab for pH positive ALL. The studies that have been done have really been limited to pH negative disease, so I don't usually use rituximab. I am generally preferring hyper-CVAD and ponatinib as long as the patient is relatively fit, can tolerate an intense course of treatment, has the necessary support to be able to, get back and forth to clinic and the hospital and so forth. I will then usually switch to blinatumomab for patients that have persistent MRD. So I won't use blinatumomab up front with this approach unless they don't respond to it very well. And then I'll generally recommend transplant either if MRD negativity was not achieved within 3 months or for patients that were not treated with ponatinib. So for those that get hyper-CVAD, got ponatinib, and have a good response, i.e. MRD negative within 3 months, those are patients I'm often not recommending a transplant. The dasatinib and prednisone induction, I'm generally deferring the use of this unless patients are unfit or have, more challenging social situations that preclude more intense chemotherapy. I will try to follow this with blinatumomab if I can, per the DALBA study. And while the data with ponatinib and blinatumomab look very encouraging, I'm not currently using this as a standard approach. I just think the follow-up on this is too short, and it's a very expensive strategy. So we'll see if more time and other studies come out that change that approach. But for now, this is how I treat this disease in my practice. Now, what about immunotherapy for pH positive ALL? So blinatumomab has been approved, at least in the US and elsewhere, for several years now. For those that don't recall, this was on the basis of 2 prospective studies. The one on the left was specifically for pH negative ALL. That was a randomized trial with chemotherapy. It was approved for pH positive ALL on the basis of a single arm study that only treated patients with pH positive disease. They all got blinatumomab, and that study is depicted on the right. It was done in Italy, called the Alcantara trial. So you can see the response rates are pretty similar between pH positive and pH negative in the relapse refractory setting. But an important limitation with blinatumomab is that it does not work particularly well when given to patients that have a high disease burden. And that was depicted both in that Alcantara study, which is shown on the bottom, and then a separate phase 2 study for pH negative disease shown on the top. So essentially, if you have a high burden of disease in your bone marrow when starting blinatumomab, here shown as a threshold of 50% or higher, your response rates are in the neighborhood of 20 to 30%, which is really not much better than traditional chemotherapy. But for those that have a lower disease burden, here again defined as less than 50%, the response rates are very high, 60, 70%. So when using blinatumomab, whether it's pH positive or pH negative disease, it's important to think about what burden the disease is at to predict how well the treatment's going to work. Well, what about inotuzumab ozogamicin, the CD22 antibody drug conjugate that's available for relapsed refractory B-cell ALL? This has been looked at specifically in pH positive ALL, though not in a standalone study. This was actually a post hoc analysis of two distinct trials that looked at inotuzumab ozogamicin as a single agent, and then looked at the subgroups that had pH positive disease. So there were 38 patients who were identified, and they compared them to 27 patients with pH positive ALL that were randomized to the standard arm on the randomized trial that got inotuzumab approved. So the Innovate trial was the randomized study that compared inotuzumab to chemotherapy. That was pH positive and pH negative disease. So there was a small subgroup of patients in both arms who had pH positive disease. The response rates in this comparison were numerically better with inotuzumab, though not substantially higher, about an absolute improvement of 10%. Much higher rates of MRD negative remissions, though, with inotuzumab. So in other words, if it works really well. The survival, however, was really no different in either of these two arms. So then that's shown here. You can see that particularly on the top curve, the patients that had pH positive disease on the Innovate study that got either inotuzumab in the red curve or the standard of care, the standard chemotherapy SC arm, very similar survival. So hard to appreciate that inotuzumab is significantly better than standard approaches here. So clearly better approaches are needed in this subgroup of patients. Well, one approach to try to accomplish that is to combine inotuzumab with a TKI, and this was a study done with bosutinib. So a TKI that isn't used very commonly for pH positive ALL, certainly not in the frontline setting. So this included 18 patients. It excluded patients that had a T315I mutation, since it would not be expected for bosutinib to work. The median age was 62. They found a maximum tolerated dose of the bosutinib at 400 milligrams daily, and they ran into some toxicities when they started to get that high, which are shown here. The response rates with this approach were quite high. 83% of patients got into remission. Most of these were MRD negative. If you compare that to the 60 or so percent response, CR rates, with single agent inotuzumab in the previous study I mentioned, so that looks maybe a little bit better. 0 deaths in the first month. Median survival is shown here, and not exactly great, but perhaps suggesting some benefit with this approach. The biggest limitation is really bosutinib is not commonly used for pH positive ALL. What if a different TKI had been used here? Maybe the response rates would be a bit better. Unfortunately, we don't know the answer to that question. The big limitation with inotuzumab ozogamicin that a lot of people worry about really is the hepatotoxicity, specifically sinusoidal obstructive syndrome or veno-occlusive disease, SOS-VOD. So there have been efforts to try to identify factors that can predict when this might occur. Some of these are shown here. So for patients who proceed on to stem cell transplantation, it's important to avoid dual alkylator conditioning, as that is thought to increase the risk of SOS. Certainly if patients go into transplant with an elevated bilirubin level or elevated transaminases, that can also perhaps increase your risk of SOS. So trying to limit the risk of this complication will hopefully improve the experience with this agent. The last immunotherapy agent in relapsed refractory ALL is chimeric antigen receptor modified CAR T cells, chimeric antigen receptor modified or CAR T cells. To my knowledge, there has been no subgroup or specific analysis of CAR T cells specifically for pH positive ALL. So while I was able to show data using inotuzumab and blinatumomab in that setting, I'm not aware of any distinct analyses of CAR T cells for pH positive ALL. So how do I approach relapsed refractory pH positive ALL? So there's relatively limited evidence that supports combining immunotherapy strategies with TKIs. So I primarily rely on single agent use of these different antibody-based therapeutics, blinatumomab, inotuzumab, and so forth. There might be a role for consolidation or maintenance with TKI after response. This is analogous to how it's used as a maintenance agent after transplantation. And as I'll show in a minute, there's also maybe some evidence to suggest this can help after CAR T cell therapy. Really what I try to do when encountering this disease, whether it's pH positive or pH negative, is I will attempt to optimize the use of these different immunotherapy agents as best I can, depending on patient-specific factors. And this was a review article that I wrote with one of my colleagues a couple of years ago on this topic, where I just sort of highlight some of the advantages or favorable circumstances for these different classes of drugs to try to figure out, when is it best to use these different agents, and then I'll try to apply that to individual patients. Now, as we've accumulated more experience and more data, there are some sort of newer indications or suggestions of how we might be able to use these drugs better, including for pH positive ALL. And one such effort is this large real world evidence study that looked at the use of brexacaptogene autoleucel, which is the product that's approved for adults with relapsed refractory B-cell ALL. So once this became commercially available, a number of researchers at different centers around the United States started to accumulate their experience. This included, when it was first reported, 30 centers. I think we're up to 31 now. Centers who've been using Brexacel for adults with ALL who contributed their experiences. The first publication from this effort was just published online about a month ago now. And this is a forest plot showing differences in outcomes among different subgroups of patients who received Brexacel for relapsed refractory ALL. I'll just call your attention to these arrows here. These were the two subgroups that were identified as having better outcomes. Interestingly, patients who had previously undergone transplantation had better outcomes. And then for those who responded, those that got either consolidation or maintenance therapy with either a transplant or a TKI, respectively, also seemingly did a bit better. Now, you can see the confidence intervals for some of these groups are pretty wide because there are just not that many of them. So you have to be a little bit cautious of overinterpreting these data. But it suggests, particularly for the pH positive patients, if they can't get a transplant, using a TKI after response to Brexacel may be favorable. Now, switching gears just a little bit, as I mentioned from the top, Philadelphia chromosome-like ALL is a distinct entity that has become increasingly recognized, and some feel deserves sort of a special therapeutic approach. And I'm just going to talk a little bit about that to provide you with some evidence and my opinions. So really the first place where this was identified was from a large children's oncology group and St. Jude's Children's Hospital experience looking at these different biological factors in high-risk children with B-cell ALL. And they found a number of different important genetic abnormalities in this large retrospective analysis. One such abnormality was the deletion of the Icaros gene, IKZF1 on 7p, that was found in a large subgroup of these patients, including some that had pH negative ALL. And when they did gene expression profiling, they were actually able to find expression signatures that highly resembled those that were present in patients that had the more canonical BCR-ABL1 translocation, and that these patients actually had very poor outcomes. And when they dissected this a little bit more, they found that these patients, their leukemia had upregulation or increased expression or increased activity in different signaling transduction pathways like JAK, PDGFR, and other ABL class pathways, suggesting that they have analogous abnormalities to BCR-ABL1, just using different biological mediators. A separate analysis that looked at 5 different clinical trials in children and adults, some 2,500 patients, were able to identify the distinct subgroups that comprise pH-like ALL. And you can see the majority of these cases are characterized by abnormalities of the CRLF2 gene. The next most common is the ABL class, but that's only about 1 in 5. And then you can see a smattering of other oncogenes involved that characterize this subgroup. And in part because of this diversity of different gene fusions and abnormalities. In order to identify these reliably, it actually requires a fair amount of sophisticated laboratory infrastructure. From this review article, they proposed a testing algorithm to try to identify these cases. I'm not going to go through all these steps, but you can see it's a pretty complicated algorithm to follow, of requiring a number of different laboratory platforms and analyses and so forth. So if you want to identify these cases reliably, it actually takes quite a bit of effort in the lab. Now, why does this matter? Well, a number of studies have shown in the last few years that indeed these patients do quite a bit worse with our existing treatment approaches. So you can see on the left the experience at MD Anderson, where patients were given hyper-CVAD. Those that had the pH-like signature did quite a bit worse than these so-called B others. So these would be the pH-negative B-cell ALLs, basically, that didn't have a pH-like abnormality. Then there was this study from Italy, similarly showing relatively poor outcomes. It may not depict very well, but it's the gray line here. But are we at a point now where we can actually do something about this inferior prognosis that all these studies are identifying? My contention is, at least in 2024, there's not a whole lot we can do about this, at least not in a unique, targeted fashion. So it is certainly appealing to think about how adding TKIs to chemotherapy could help these patients. The evidence that supports that is largely from very small series in patients that got standard chemotherapy that failed and then got TKIs added to it. So clearly not a standard kind of upfront strategy. There are several ongoing trials that are looking at that approach, though, where it's a priori added to chemotherapy. We just don't have results on that yet. And even if they are successful, how feasible this is going to be is not clear. Some of these genes don't have very good targets. Some are not approved for pH-negative ALL. And in my contention is that pH-like ALL will often declare itself as high risk using more typical and established methods, including having persistent MRD after a standard course of treatment. And we have pretty good existing paradigms of care for those patients already, including giving them blinatumomab and switching to transplantation. Furthermore, when pH-like ALL responds really well to chemotherapy, it's not clear that transplant in first remission actually helps. So a lot of people say, well, we should transplant these patients up front because of their poor outcome. Well, there's actually some data to suggest even if you have these high risk features, if you have a good response to chemotherapy, you actually do very well, including without upfront transplant. So when you think about these different issues and then how complex the testing could be to identify them, one could argue that we shouldn't even be looking for it at all. If it's hard to find or it requires a lot of effort and you're not going to do anything with the result, why even bother testing for it? I'm not suggesting that that's the right way, but it's an argument that could be made. So the last topic I'll talk about, my last few minutes, is MRD testing, which is important for for ALL broadly, but has become increasingly important for pH positive ALL. So while a lot of us are familiar with MRD testing from clinical work, it's important to appreciate at least some of the technical aspects of this testing. This is a curve just showing a few different scenarios for depicting kind of depth of response and what that can mean over time. So when you're either ordering or evaluating MRD results, it's important to know when it was tested, how good was the sample that you collected, was the assay that you used appropriate, and could previous treatments have actually impacted the results of your test. So when to test for MRD and ALL, according to the NCCN guidelines, end of induction, end of consolidation, and then a fairly vague recommendation of additional time points guided by the regimen used. So it's important that you know what regimen you're using when you try to apply these practically, because these terms are not necessarily universally accepted across different treatments. So when they say end of induction, that usually means around 3 to 4 weeks into treatment. End of consolidation is generally around 3 months. So you could sort of apply those timelines to whatever regimen you're using in order to apply this approach. When do I test for MRD? This approach is largely true both in the frontline and the relapsed refractory setting, but I will do it at the end of induction at times shown here. I will do it at the end of consolidation, particularly those that are MRD positive after induction. After any kind of intensive therapy before switching to maintenance therapy, I'll check again at that point to make sure that they're still MRD negative. Before patients go to transplant, we will often check it. Sometimes those align with some of these other time points, though. But I'm generally not using MRD as a post-treatment surveillance strategy. I won't get into that specifically, in part because we don't really have good data, but certainly something that I could address if questions come up. It's important that you understand how to collect samples properly for MRD testing, and it's also important to recognize you may or may not have control over this as a clinician, depending on how your system works. So it's important that you do the right baseline or pre-treatment testing. It's really important that you avoid hemodilution in a bone marrow aspirate sample, that you should really only use the first couple milliliters of the first pull for MRD testing. Any material beyond that is largely going to be replaced by peripheral blood. In general, it's best to wait until peripheral blood counts have improved before collecting a sample, because you need adequate cellularity in your sample in order to optimize the technical aspects of the test. In terms of the different assays available and how prior treatment can impact that, it's a bigger issue for multi-parameter flow cytometry. Not all assays are the same. One place's flow cytometry is not going to be as good as another. It's important that you know what your local lab uses, if that's what you're relying on, or what your reference lab is using. Ideally, it's a test that can measure down to a sensitivity of 0.01%, or about 10 to the negative fourth. The nice thing about flow is it includes immunophenotype and disease burden. So when we're thinking about using antigen-targeted therapeutics, flow will actually provide you the information you need for this. And it's important that your pathologist knows about any prior antigen-targeted therapy. A lot of gating strategies for BALL are based on the presence of CD19. It's such a ubiquitously expressed protein. A lot of flow cytometry assays, you look for it. But of course, if patients have gotten a CD19 targeted treatment and no longer have that on their leukemia, the flow cytometry could completely miss it. So if the pathologists know this in advance, they can use alternative strategies to look for the residual leukemia. Well, how can we use MRD to guide treatment decisions in pH-positive ALL? Well, there have been mounting data to suggest that you can actually probably defer transplant in this setting. So this study was done at MD Anderson exclusively, looking at years of experience giving hyper-CVAD and TKI, and they looked at distinct levels of response, including either by BCR-ABL, RT-PCR was the assay used here, either by achieving a complete molecular response, so no detectable transcript or less than 0.01%, or more of a CML type definition of major molecular response, which is basically 1 log higher. And what they were able to show is essentially at 3 months of treatment, the deeper remission you were in, the better your outcome was. And that's the red curve is the complete molecular responses. Taken a step further, this was a multi-center retrospective analysis that looked at patients who had achieved that depth of response, complete molecular response with hyper-CVAD and a TKI. And then they looked at whether or not patients were given a transplant in that deep remission. And what these investigators found is that giving transplants to these patients didn't really improve their outcomes very much. It did seem to reduce the risk of relapse, which is shown in the bottom left, but survival really wasn't improved, suggesting that this might be a way to identify patients who are unlikely to benefit from transplant up front. Now, the downsides of relying on the BCR-ABL test for your MRD assay of choice in this setting is that the oncogenic transgene that you're trying to exploit may not be unique to the malignant lymphoblasts. So BCR-ABL1 can be found in both myeloid and lymphoid cells. So think about CML. You can see it in myeloid cells. The methods that exploit either immunoglobulin or T cell receptor clonality are restricted, however, to the lymphoid lineage. So those are going to tell you exactly what's going on with the ALL. They're not going to be disrupted potentially by this possible expression in myeloid cells. A cohort of children with pH-positive ALL was looked at and actually could identify a subgroup of patients that have the BCR-ABL transcript in these different lineages of cells, not just the B-ALL cells, suggesting they had a so-called CML-like biology. And similar phenomenon has been observed in adults. So they were in a study from France, they found that about 40% of patients had discrepant MRD kinetics after treatment. So in other words, their lineage-specific ALL specific assay showed MRD negativity, but the BCR-ABL1 transcript was still detectable by RT-PCR. And what they found is that as long as you achieved a deep remission by that immunoglobulin or T cell receptor rearrangement test, that's really what was prognostic, that the BCR-ABL testing was not as useful. Again, probably speaking to this underlying CML type biology that may have less prognostic significance. So how can we improve upon MRD testing? So high throughput sequencing or next generation sequencing is an approach that is now available in some jurisdictions. So it's commercially available in the US and elsewhere through the clonoSEQ assay by the Adaptive Biotechnologies company. It's more sensitive than flow or PCR, probably by 1 or 2 logs. It has good concordance between blood and bone marrow, so you can actually potentially spare bone marrow exams at some times, though I'd probably still do bone marrow tests at critical time points like the end of induction. It is virtually always positive if a less sensitive assay like flow is positive. So if you're doing both on every sample, you're probably being a bit wasteful. You could probably try to do it in a more stepwise fashion, do the flow cytometry first and then reflex to this assay if it's negative. You can also get these discrepant results with the BCR-ABL RT-PCR, similar to the studies I showed on the last slide. So this can potentially identify those cases that are sort of CML-like. It does not rely on immunophenotype, which has good things and bad things associated with it. So if you do lose antigen expression during treatment, it's not going to affect your results. However, if you're wanting to intervene on this assay with something like blinatumomab or CAR T cells, you're not going to even know if CD19 is present because it doesn't report the immunophenotype. It just tells you how many cells are thought to be present in the sample. So when comparing these two different assays, flow cytometry, high throughput sequencing, HTS is more sensitive, but it lacks the immunophenotype. The results usually take a little longer. I would argue it doesn't add a whole lot to high quality flow cytometry. It's definitely more sensitive, but as I'll show on our next slide, there's really a lot that it's missing still, despite it being a little more sensitive. If your options are either a high throughput sequencing based MRD assay and a lower quality flow assay, definitely I would say go with the high throughput sequencing test. It's better to have more sensitive than less. But I think we still need to do a better job of optimizing how these assays are used in clinical practice and when to test and how to test and so forth. But this leads me to my last point, which is, kind of a thought experiment in this idea of, absolute zero. So how low do we have to go to really be confident that the disease is gone? So there have been a number of computational biology evaluations that have looked at questions like this, and it's thought that we have about 10 to the 12th immune cells in our body. Looked at another way, if you just count up the number of leukocytes in our blood, it's on the order of about 10 to the 10th. Our bone marrow can make 10 to 11 neutrophils per day. So when you put all this together, if we wanted a test that could look at every single immune cell in our body and tell us if it's cancer or not, it would need a sensitivity around 10 to the negative 12th. So that's 6 orders of magnitude more sensitive than what HTS can do under the optimal circumstances. So really, if you're MRD negative by this test, yeah, it's good, but it's not really all that reassuring because there's a lot that it's not seeing. So to conclude, the treatment landscape for pH positive ALL is really evolving rapidly. There are several options now that exist for the frontline treatment. Ponatinib is arguably now the preferred TKI. But what we use with that or what other agents we might consider is still an open question. Immunotherapy agents are active in the relapsed refractory setting, and how we combine them with TKI is still not clear. pH-like ALL is a distinct entity, but I'm not sure we should be treating it any differently. Maybe in the future we will be analogous to how we treat pH-positive ALL. And it's important to think about how MRD testing can be used in this disease because it can potentially be used to guide treatment decisions. So with that, I'll conclude. Thank you very much for your attention, and I'm happy to take any questions if there are any.
Thank you, sir, for that fantastic and lovely talk. Now I request all our discussants to please put the hand raise sign so that we can start our question answer session with Dr. Ryan Kasade. Yeah, Dr. Ramesh, your question.
Sir, that was an excellent presentation. Many of my doubts were clarified in your presentation itself. So I have only a couple of questions to ask more. My first question is like any role of asciminib, any data on the role of asciminib in pH positive ALL?
So there are very limited data right now using asciminib for pH positive ALL. There are certainly several ongoing studies that are looking at it in different settings, either in combinations in the relapsed refractory setting, frontline treatment. Right now, I've only used it a few times in my clinical practice in patients that had multiple prior TKIs that had progressed through, ponatinib and nilotinib and all the other agents. It is, available, and I predict that it's going to be active and effective in these clinical trials. But for right now, in terms of evidence-based approaches, there really aren't any. But almost certainly in the next couple of years, we'll have more studies.
Do you think like it has been approved recently for for CML in the front line? Do you think much more studies will evolve in the pH positive ALL also? Probably.
Yes, I agree. One thing, of course, that's unique about ALL compared to CML is the issue of CNS activity, because it's so important that we treat that part of the body in ALL. I don't know how much is known about the CNS penetration of asciminib. So if it turns out to not be very active in the CNS, that might prove to be a limitation of the drug. So I'm not sure it's going to completely replace or become the agent of choice up front. It's possible that it might. We'll just have to see how the studies bear out.
Okay, sir. My second question is like, is there any difference in the management of pH positive ALL and CML with lymphoid blast crisis?
I would say not very much. In my practice, I might be more inclined to use a chemotherapy-based approach as opposed to an immunotherapy-based approach, just since as good as blinatumomab is for B-cell ALL, it's not really going to have any activity on the underlying CML. Obviously, chemo isn't necessarily great for CML either, but it's probably going to have more activity. The second thing is these are definitely the cases where you can get these discrepant MRD tests where you can have the persistent BCR-ABL1 transcript, but either flow or HTS or whatever will be negative. So it's important to appreciate that distinction, that just because the BCR-ABL is still present, it doesn't mean their leukemia, their acute leukemia is still there. It could just be residual CML. The last thing I'll say, particularly for patients that had chronic phase CML for many years that were on TKIs and then progressed to lymphoid blast crisis, those are patients that I'll recommend a transplant up front. So the point I made earlier about deferring transplant for patients that get into a deep remission, I would really only apply that to de novo pH positive ALL. I think if you have CML and lymphoid blast crisis that has previously received multiple TKIs, those are distinctly different patients that have a more aggressive, poor prognosis, is my suspicion, and that you should try to get those folks to transplant up front if you can.
Thank you.
Thank you, Dr. Ramesh. So there are some couple of questions from the audience. Yeah, the first question is from Dr. Sinwin. She has a 30-year-old Philadelphia positive B-ALL patient after induction by pediatric-inspired regimen with ponatinib showed MRD negativity by flow cytometry, but BCR-ABL is positive. What is your opinion for further management?
Yeah, so I think this is a good example of this issue of discrepant MRD tests in pH positive ALL and how they might confuse or complicate matters. So if your flow cytometry test is relatively high quality, meaning 0.01% sensitivity, I would interpret that as a very good response, particularly at the end of induction, and that residual BCR-ABL transcript, I mean, it's certainly bad. It's related to disease, and I don't mean to imply that it's like okay, but it probably reflects some underlying more stem cell CML type biology where the kinetics of response are going to be a lot slower. The risks in terms of short-term prognosis and so forth are going to be different. Ultimately, it's going to be important that goes away if your treatment is going to be deemed successful, but I wouldn't use that test when you have a negative flow cytometry test as evidence that, oh, the treatment has failed, we got to send this patient to transplant and so forth and so on. Again, and I think maybe the best data for that is that French study that I cited that was just published this year in JCO, where if you have these two different tests and you get discrepant results, it's the one that's more specific to ALL, here the flow, that's probably more prognostically significant than the BCR-ABL test.
And from the same note, sir, if it was after the end of consolidation, then the same thing, flow negative and BCR-ABL positive at the end of consolidation.
Yeah, I think at that point, I would not necessarily think, oh my gosh, this patient is going to relapse or whatever. I might be a little bit more hesitant to defer transplant up front. In other words, since the data we have for that decision is based solely on the BCR-ABL transcript, that retrospective study published in Blood that looked at those that achieved complete molecular response that didn't get a transplant or not, since this patient would have not reached a CMR, it would be hard to apply those data to this patient. So it might be somebody that you would consider for a transplant up front, even though the other tests were negative. And the justification there is the transplant will hopefully address, the underlying CML component too, if that is indeed what's driving that, and hopefully prevent, future relapses. But I wouldn't necessarily switch to blinatumomab or completely change the treatment or whatever. I'd probably continue, but try to get them to transplant.
And would you change the TKI at this junction?
Probably not. It would depend a little bit, I think, on how high that BCR-ABL transcript level is and how much it had changed. So for example, if at the end of induction, it was like, I don't know, 1% or something, but by the end of consolidation, it was down to 0.01%. Like if it was clearly decreasing on the ponatinib-based approach, I would probably just stay with ponatinib. If it had dropped and then stayed stable, I would be more nervous. The problem, of course, with the ponatinib-based approaches is we don't necessarily have, to Dr. Ramesh's question earlier, what would we use? Like, what would the alternative be? If ponatinib is viewed as the best TKI and that doesn't work, we don't necessarily have a logical choice. I mean, you could certainly try asciminib, but again, you're not going to have any evidence to support that. Maybe it'll help, but we just don't know. So it's tricky. So I would hope that it was getting better, in which case I'd probably just stick with ponatinib.
Thank you, sir. Dr. Hita, you have a question?
Good evening, sir. Thank you for that wonderful presentation. Sir, I have one doubt. Sir, during the induction chemotherapy, many of the patients have prolonged cytopenias, thrombocytopenia. So what level of platelet cutoff will you use? You use to start from ponatinib and dasatinib. How do you use the TKIs while induction when they are in cytopenic phase?
Yeah, so I would say my practice generally is, once we've established that the patient has pH positive disease, which we will usually do before we start any kind of treatment, we will include the TKI upfront with the start of chemotherapy, but we will usually only limit the TKI to 14 days during induction. So we'll continue it for the first 2 weeks of induction and then hold it. Obviously, that's not great from a cancer treatment standpoint, but to your point, since a lot of these patients are going to have significant cytopenias because of their leukemia, and then it gets compounded by the treatment you just gave them, holding the TKI might allow their blood counts to improve more quickly so that they're not cytopenic for so long, and then you're delaying the next cycle and so forth. Once you get them through that first cycle, since the vast majority of patients will have a good response and then their blood counts will get better, they usually have a little bit more tolerance of some of the hematologic toxicity. So then with future cycles, you can usually give it continuously without that interruption. So that's usually what we will do, is to stop the TKI after 2 weeks to hopefully allow for better hematopoietic recovery.
Any other question, Dr. Hita? Fine. Thank you, sir.
Yes, sir.
Yeah.
Thank you.
Sir.
Another question has come up from Dr. Sinwin. She has a rare case of 14 years old boy, Philadelphia positive TALL, showed MRD as well as BCR-ABL negative after ponatinib plus hypersevere regimen after cycle 1A and 1B. And the ponatinib was then used as the dose of 15 milligram. And after cycle hypersevere 4A and 4B, he's still having MRD negativity by flow as well as BCR-ABL negativity. Please give your suggestion regarding the maintenance part of this regimen.
Yeah, so the studies that have been done prospectively using TKI and chemotherapy where transplant wasn't used, the maintenance that has largely been used is continuing the TKI, usually daily, and then including, similar to POMP that we use for pH negative ALL, pulses of vincristine and corticosteroids every 4 weeks, potentially for up to 2 years. So the hyper-CVAD strategies use that. I don't know specifically about the EWAL study or the Falcon trial. I think they use the same. The EPOC study that we did at the UW and Fred Hutch used that approach as well. So essentially, you're giving POMP just like you would a pH negative ALL, except you're taking out the methotrexate and mercaptopurine and adding the TKI. So then you do that for 2 years. The problem is we don't know that you can usually stop confidently at that point. How long to continue the TKI is an open question. I usually tell patients that we'll continue it for at least a couple more years if they're tolerating it. I don't think, particularly a 14-year-old, I don't think they need to be on it for the rest of their life. So there may be more data coming out that help us guide when to stop TKIs, particularly now that we have more data about not doing transplants up front. So I don't think it needs to be lifelong, but I usually tell patients indefinite, meaning we're going to continue it for a while. And maybe after a couple of years, we'll stop it depending on how they're doing.
Thank you, sir. Another question from Dr. Karthik. Any role of blina versus inotuzumab in MLL rearrange ALL?
Yeah. So both agents can be used. They don't work as well as the other subgroups of relapsed refractory B-cell ALL, whether that's because they have less of the target antigen expression, or there's just the unique biology of MLL or KMT2A rearranged disease. So they certainly can be tried. I would just be less optimistic about how well they're going to work. Just this week in the US, at least, there's a new agent approved, revumenib, which is a menin inhibitor that was approved for relapsed refractory KMT2A rearranged acute leukemias. So that's ALL, mixed phenotype acute leukemia, and so forth. The data with that agent are not necessarily amazing. They certainly are encouraging. So that is a new agent now for that subgroup, at least where the drug is available. Is it better than blinatumomab or inotuzumab? Not as good evidence, I would say, but certainly worth considering.
Thank you, sir. Another question Dr. Karthik has is, do you do bone marrow at the end of treatment for MRD status?
I do. Like at the end of maintenance therapy, like I said, for somebody with pH positive ALL or pH negative ALL, when they're done with their maintenance therapy, that's another time I'll do a bone marrow test to really be absolutely certain they're still in remission. From a practical standpoint, I'll use that to reassure the patient we can take their port out, that they don't need any more treatment, and so forth. Beyond that, I usually don't do bone marrow tests unless patients develop signs or symptoms that are concerning for relapse, like they have a new cytopenia or whatever.
Thank you, sir. Another question Dr. Karthik has is, if we use pediatric ALL protocol in pH positive adult ALL, is there then still a role of transplant in this case, in this scenario, if you're using pediatric based ALL protocol, it's a pH positive adult ALL?
Yeah. So I'm not saying that treatment is wrong. I will just say that I don't typically use pediatric inspired regimens in this setting. I generally only use them for pH negative ALL. Now, that being said, the pediatricians use pediatric inspired regimens for pH positive ALL, which is why this approach is not wrong. Those studies, and again, remember, pH positive ALL is very rare in kids. It's like 2% or 3% or something. So the studies in that setting are not as good. But when they use these approaches like a COG, asparaginase containing regimen and so forth, and then include a TKI, they've been able to show, at least in one study I can think of, that transplant upfront does not appear to help. Okay. So I think if you're using an approach like that, and if you included a TKI, and I think if they've met all the necessary milestones in terms of MRD clearance and so forth, I think you can omit transplant upfront. Is that a better way of avoiding transplant upfront than, say, hyper-CVAD and ponatinib? That I don't know. I think the evidence is maybe getting better for the hyper-CVAD based approaches, again, in part because Ph positive AL is so much more common in adults, even though the total numbers are less, the incidence is a lot higher.
Thank you, sir. Another question from Dr. Karthik. A patient of PH like ALL on chemotherapy has attained MRD negativity at CR1. Will transplant still be indicated, or should we continue with chemo?
Yeah, so that's a situation I mean, people will disagree on this point because we really don't have any good evidence, but I would not recommend a transplant for this patient. I think given the excellent response to chemotherapy, this sounds like, even though it has a high risk biologic feature, from a practical standpoint, this sounds like it's chemotherapy sensitive disease, and thus I would continue with chemotherapy. If it is available, you could consider incorporating blinatumomab into the treatment, like was studied in the E1910 trial that was just published earlier this year that improved survival. That included some PH-like cases. If it's not available, though, I wouldn't use that as a justification for transplant. I would still continue on with chemotherapy through the full course that you were planning, and then the 2 years or so of maintenance after that. I can't, of course, promise that this patient is going to be cured, but my suspicion is that their chance of cure is good enough that it doesn't justify the risks associated with transplantation.
Thank you, sir. Another question from Dr. Shyam. Do you prefer ponatinib for every newly diagnosed Ph positive ALL in 2024, 2025?
It is generally our preferred TKI now, but there are certainly circumstances where I would be more concerned about it. Certainly patients, even though with these modified dosing strategies and so forth, it looks like the risk of cardiovascular toxicity from ponatinib isn't as high. If somebody has like active coronary artery disease, like just had a myocardial infarction or multi-vessel coronary disease and so forth, I may be more nervous about using ponatinib in a patient like that, and might instead prefer dasatinib. The problem, though, is, while it's more significant with ponatinib, in some respects it's a class effect. It's maybe less frequent with imatinib, but all the TKIs have the potential to either exacerbate or worsen atherosclerosis through mechanisms that I'm not smart enough to understand. But so you can't necessarily completely avoid this risk unless you're going to give them like imatinib, which is really not probably the best way to treat their ALL. So really, other than that, or if there's like some unique cost consideration where they just can't afford the cost of the ponatinib, we would use it as our preferred drug.
Thank you, sir. Another question from Dr. Mohammad Rifai. What is your protocol for treating Ph positive T cell ALL?
Yeah, so I have seen a total of 2 of these cases in my life. So we don't have a standardized approach. This is a really rare situation. It tends to be associated more with lymphoid blast phase of CML when it is seen. So given that, and speaking to some of the questions that came up before, I would generally prefer a chemotherapy-based approach with a TKI, again, preferably ponatinib. I would generally probably not use the blinatumomab-based approaches unless the patient, well, of course, I wouldn't use blinatumomab for T-cell ALL because it's not going to work because it doesn't have CD19. But I would generally recommend a transplant up front, I would say, again, because of the tendency for these to be associated with CML, and that you may not adequately treat that component if you only use chemotherapy alone. But if it's an older patient, doesn't have good social support, lacking comorbidity, or has a lot of comorbidities or whatever, if they have a good response to chemo and TKI, I would at least continue with that. If I could transplant them up front, I probably would recommend it, though.
Thank you, sir. Another question from Dr. Mohammad Hussein Mir. Can transplant be totally avoided in the era of ponatinib-based regimens today? And if so, which patient group should be selected for transplant if ponatinib-based regimen has been used?
Yeah, so I don't think we can completely avoid it. And I think it's largely going to be dictated by response to therapy. If we look at the ponatinib and blinatumomab study, so if you're using that approach, as I mentioned in the slides, only 2 of those 60-some patients got a transplant up front. So that, of course, is not going to be enough to tell you how to use transplant in that setting. With the hyper CVAD-based approaches, I would still use MRD as an important stratifier for how well that treatment is working. As I said before, the BCR-ABL transcript level is where most of the data are with respect to transplant and so forth. But because of this possibility of discrepant results with, other sensitive tests that are going to look more specifically for the lymphoblastic leukemia, if I had a patient that had, hyper CVAD and ponatinib, and after, consolidation, so 3 months of treatment, they were positive by both BCR-ABL and a sensitive flow cytometry assay showing that it was residual B lymphoblasts. That's a patient I would be very nervous about giving chemo alone. That's somebody I would probably switch to blinatumomab and then try to take them to transplant. So I would generally use the MRD kinetics and the pattern of results to sort of decide who gets a transplant and who doesn't. If they have a really deep response on ponatinib, I'll generally not recommend a transplant though.
Thank you, sir. Another question from Dr. Homdutt. How to approach to isolated CNS relapse treatment as medullary relapse or as a high dose methotrexate CNS irradiation? How do you approach that?
Yeah, very challenging situation. And I think this would be true of both pH positive and pH negative ALL. I would generally, as long as they're young enough and fit enough, I would generally use focus more on CNS penetrating therapies as opposed to continuing with a more traditional relapsed refractory medullary relapse type situation. So for example, particularly in adults now where we're using very little chemo in this setting and we're primarily using things like inotuzumab and blinatumomab and so forth, there's really very little evidence that those agents are effective in the central nervous system. Okay. So they might be useful as an adjunct or as a consolidation type approach or something, or for patients that have a concurrent medullary and CNS relapse. If you've cleared their CNS, but you're still treating their medullary disease, certainly using those agents in that setting could be useful. But in general, for an isolated CNS relapse, I would favor using more traditional cytotoxic chemotherapy that can penetrate the CNS. And it's important to remember ALL is, sensitive to lots of different chemotherapy agents, and a number of different agents can cross the blood-brain barrier. So, it's not like an aggressive lymphoma where you just give high-dose methotrexate. Asparaginase effects cross the blood-brain barrier, cytarabine, mercaptopurine, dexamethasone. So a lot of regimens out there that have used these different combinations to try to get as much drug into that part of the body as possible. Those are also patients I am generally referring to a radiation oncologist to talk about CNS-directed radiation strategies as well, because of the risk of not eradicating the disease with chemo alone. So,
thank you, sir. Another question from Dr. Shyam. Is cytarabine-based chemo protocol must for all pH positive ALL?
I would say no. I don't think it's a must for all. Certainly, as I mentioned in my practice, for younger patients that are fit, I'm still using, multi-agent chemotherapy plus TKI. Hyper CVAD is the regimen I use, so it's got cytarabine. But for older adults, for those that you're nervous about the side effects, some of these more chemo-free approaches that use TKI either in combination with or some sort of transition to blinatumomab, I think is a perfectly reasonable approach.
Thank you, sir. Another question from Dr. Nakul Tikare. Isolated CNS relapse in pH positive ALL or isolated CML blast crisis involving CNS only, how would you recommend to monitor the diseases? Is BCR-ABL monitoring in CSF feasible or reliable?
I am not aware, I'm not a lab medicine expert, so I would hesitate to be too confident in this, but I'm not aware of any good evidence out there of using the BCR-ABL assay on CSF. It's possible that it's technically feasible. And I guess, you could talk to your laboratory to see if it's possible. You could send them a sample during relapse to see if they can detect it. And if they can detect it and it's feasible, I guess you could use it and then extrapolate from our experience with blood and marrow. Things like how fast it has to clear, low level positivity, and what does that mean? It's harder to know. And it's important to remember CSF is nowhere near as cellular as blood and marrow. So there's just way fewer cells. And a lot of MRD assays, their sensitivity is in part based on how many cells are present, right? So you can't be confident that an assay is sensitive down to 1 in 100,000 cells if you've only got 30 cells in your sample, right? So CSF is so hypocellular or paucicellular. It may be that it loses some of the quantitative aspect and it's really more of a qualitative assay. In other words, it's positive or negative. But again, I'm not aware of any good evidence for it. But if your lab can do it, it is sort of an appealing idea as an adjunct to other methods.
Thank you, sir. Another question from Dr. Mohammad Rifai. In pH positive ALL, if you're treating with ponatinib plus hypercived, will you consider prophylactic renal radiotherapy?
Generally not prophylaxis. Certainly intrathecal chemotherapy as part of that treatment. The only circumstances where I would use cranial radiation in somebody getting a hyper-CVAD based approach is if they had detectable CNS disease at baseline. And it's not prophylaxis, of course, then it's more of a consolidation strategy. So if their CNS was negative up front and they've gotten an adequate number, 8, 10 or so doses of IT chemotherapy and responded well in their bone marrow and so forth, I would not generally recommend radiation for those patients.
Thank you, sir. So I've finished all the questions from the audience. Any discussion you want to ask any other question? Fine. So, sir, thank you so much for that very lengthy discussion and a fabulous lecture as always. Fantastic, superb. Hats off to you.
Thank you.
Lovely discussion. You solved so many doubts of us. Thank you
Good.
for being you here today. Thanks a lot, sir.
All right. Thank you very much. Best wishes to you all.
Thank you. Thank you. Thank you, sir.